October the 2nd, a young female patient was admitted to the emergency room of the University Hospital Lübeck, and she was found seriously injured on the railroad tracks. She got caught by a train, and her right leg was amputated, and her left leg was open fractured. She immediately underwent surgery, and her right leg had to be amputated above knee, and it was unclear if they were able to save the other one. And after surgery, she was transferred to the intensive care unit. And 2 days later, we saw the patient for the first time in psychiatric consultation. And at this point, it was clear that this was not an accident, but an intended self-injury. And the patient had a history of self-injuries and hoped that through this drastic accident, the pressure for self-harm and suicidal ideation would end once and for all. And she didn't want to die in this accident, and she said that she's glad to be alive. And she grieved for the loss of her leg and was worried about losing the other one as well. And while she was at the intensive care unit, she was seen on a regular basis by us psychiatrists. And on the 18th of October, just 16 days later after this accident, she reported again from suffering from high self-harm pressure and suicidal ideation. And in the following days, she became increasingly destabilized with a lack of commitment for physiotherapy, regular intake of pain medication, as well as antibiotic treatment. And no sufficient commitment for the planned orthopedic rehabilitation could be built up. And just another 11 days later, she strangled herself with an infusion cable and was found cyanotic by the nursing staff. And she was not distanced from acute suicidality and was severely impulsive, and therefore she was transferred to our psychiatric department. So, for us, the patient was already well known, and she's a 21-year-old woman, single with no kids, and currently lived in Lübeck. And using the SCID 1 and 2 for DSM-4, and according to the criteria of the ICD-10 classification, she was diagnosed with a borderline personality disorder, a severe recurrent depression, and a social phobia. And she suffered from emotional instability and had difficulties in dealing with intense anger. And she reported from impulsive behavior, suicidal behavior, and severe self-harm. And she had chronic feelings of emptiness. And her relationships were described as unstable with extremes of idealization and devaluation. She also suffered from dissociation as well as depersonalization and derealization. And she reported for mainly depressed mood with a diminished interest in almost all activities as well as a loss of energy. So she could spend hours and hours ruminating, and her ability to concentrate was diminished. And she intensely suffered from her own indecisiveness. And social anxiety already appeared in kindergarten. And she had difficulties in speaking in front of her class, fearing that something embarrassing might happen to her and will lead to rejection. And as a teenager, symptoms worsened considerably. And at the age of 16, first suicidal thoughts and the first self-injuries occurred. And from then on, symptoms took a very drastic course. So the patient received already intensive psychotherapy, and she was treated in child and adolescent psychiatry for social anxiety and a borderline personality disorder, and changed to our psychiatric department at the end of 2018. And in the years 2019 and 2020, she was treated 21 times in our psychiatric department. And in a more detail, she spent 431 days as an inpatient or in our day clinic. And treatment was characterized mainly by crisis interventions or short inpatient or day clinic treatments. And intensive inpatient psychotherapy or regular outpatient treatment was never possible in the long term due to numerous self-injuries and acute suicidality. And since the end of 2016, over 1,000 self-injuries with cutting, icing, burning were reported with an almost daily frequency. And the longest time period without self-injuries in the last few years were 20 days while she was an inpatient. And she had several suicide attempts, like with intoxication, with medication, strangulation, or throwing herself in front of a train. And last year in September, she tried to commit suicide 3 times just within 2 weeks, and twice with high doses of prescribed lithium. So regarding her biography, she raised up with her parents and her younger sister. And when she was 5 years old, her parents got divorced and she lived with her mother. And due to moving, she had to change elementary school 3 times. And her mother got into a new relationship, and therefore she had already, another younger stepsister. And in kindergarten and school, she felt withdrawn and had very little friends, or a few good friends. And after graduating from school, she began to study mathematics in medicine and life sciences in Lübeck in 2019. And she lived in a shared flat. And the relationships to her family was described as okay, but not always easy. And because symptoms worsened dramatically over the last year, she wasn't able to continue her studies, and she lost her flat and had to move in with her father. So the patient was treated according to the dialectical behavioral therapy concept. And DBT is a cognitive behavioral treatment program developed to treat suicide patients meeting the criteria for borderline personality disorder. And DBT is specialized in reducing suicidal ideation as well as self-harm or self-destructive behavior. And so she received first-line or guideline-based psychotherapy and didn't benefit from it. And in addition, she received a variety of pharmacological treatment, like antidepressants of different types, as well as lithium as a mood stabilizer and anti-suicidal substance. Also antipsychotics and a variety of low-potency antipsychotics, as well as benzodiazepines in acute settings. So, but let's go back now to October, to the end of October, when she was admitted to our psychiatric ward. So she was severely emotional and unstable and felt high pressure to harm herself and suffered from suicidal ideation. And on the 5th of December, she injured herself with 7 deep cuts in her right forearm. And the reason she had cut off her leg, namely to perform a final self-harm and feel better in the long run, didn't work out, and the costs for her were very high. So now let's summarize. We have a young female patient, highly suicidal, high pressure to harm herself severely. She was highly DBT experienced, and she was tending to get worse instead of getting better under high-frequent DBT therapy. And she had done the most drastic thing to treat and cure herself, but nothing worked. So we asked ourselves, what shall we do when our therapy has failed so far? And then we thought the most important thing is to rapidly reduce suicidal ideation and self-destructive behavior that had blocked successful treatment so far. But what do we know about treating suicidality, and what's an effective intervention, and how can we quickly achieve change in suicidal ideation? And current treatment options for patients at acute risk for suicidality are limited and generally consists of hospitalization, pharmacotherapy, psychotherapy, or a combination thereof. And treatment with lithium and clozapine, as well as DBT or CBT, have shown to reduce suicide deaths and the rates of suicide attempts. But while these treatments have shown to reduce suicide risks in the long term, they have not shown to be effective in acute settings. So, are there any options to rapidly reduce suicidal ideation? And yes, there are. And so we took a deeper look at ketamine. So ketamine, in a nutshell, you have already heard, is a glutamatergic NMDA receptor antagonist and commonly used in anesthesia or emergency medicine. And since the year 2000, several clinical trials have found out that subanesthetic doses of ketamine had rapid-acting antidepressant and anti-suicidal effects in patients with mood disorders. And a landmark meta-analysis by Wilkinson and his colleagues found out that ketamine, a single infusion of ketamine, rapidly reduced suicidal ideation just within 1 day after the infusion, both on clinician-administered and self-reported outcome measures. And in this study, they used for the clinician-administered the MADRS and the Hamilton, and for the self-reported outcome measures, the Beck Depression Inventory and the QIDS. And these effects lasted for about 7 days. And a randomized controlled trial from Grunebaum and colleagues showed that ketamine was also associated with a rapid reduction in suicidal ideation. And these improvements were maintained up for 6 weeks. And in this group of patients with a major depressive disorder in the ketamine group, also 11 patients were included with a borderline personality disorder, which didn't have any effective on the results. So, also encouraged by the clinical, by the early results of the clinical trial ketamine and borderline personality disorder. I forgot another thing. And And in treatment-resistant depression, patients respond to a single infusion of ketamine in a response rate over 60% just within a few hours after the infusion. And since patients with a borderline personality disorder have very little response to SSRIs or other antidepressants, we hope that ketamine would also be effective in these patients. And because patients with a borderline personality disorder are much times more likely to commit suicide, there's a great need of rapid-acting antidepressant treatment. So, encouraged by the early results of the clinical trial Ketamine and Borderline Personality Disorder from Sarah Feinberg and her colleagues from Yale, and considering the insufficient response to the previous treatment, we decided to treat her using with ketamine. And then what happened? So on admission at the end of October, she was medicated with quetiapine 200 milligrams per day, received gabapentin and hydromorphone as pain medications, and was substituted for folic acid and iron deficiency. And we measure depressive symptoms and borderline symptoms were measured with the Beck Depression Inventory and the borderline symptom lists, both self-reported outcome measures. And initial values 2 days before the first infusion, as baseline were 34 points of the BDI of 63, which means a severe depression, as well as by the BSL-23, 63 out of 93 points. So, on the 14th of December, it was a Monday, she received her first ketamine infusion with 0.5 milligram per kilogram body weight over a time period of 45 minutes. And she reported that this infusion was sometimes very uncomfortable for her. So sounds were perceived differently, as if really far away, and she had an altered perception of time, so everything went really slow for her, and everything felt lighter, and she also reported an altered perception of her body. So, for example, she felt like her hands were made out of rubber. So, and just 48 hours later, these changes occurred, and mainly item 9 of the BDI regarding suicidality decreased. And same week on Friday, just 4 days later, she received another ketamine infusion, and these changes occurred. So she said that she wasn't feeling so sad anymore, and she didn't feel so hopeless regarding her future. Also, her highly self-critical thoughts changed into a more objective perception of herself. She reported to have more energy, and most importantly, she felt less urgent suicidal thoughts. So she was able to quickly stabilize, and she was motivated for the planned orthopedic rehabilitation. Oh no, I forgot another thing. I'm sorry. So here you can see the changes that occurred in the BSL-23 from baseline to after the second infusion. And mainly improvements were trusting in other people and believing in her right to live. And she got a more objective view regarding the fascination of death. So because she was stabilized really quickly and gave her commitment for the planned orthopedic rehabilitation, she was discharged at the 23rd of December. And then what happened in the following weeks and months? 4 weeks later, symptoms worsened again, and she was admitted to our psychiatric ward and received another 2 ketamine infusions. So that she was able to stabilize really quickly so that she could get back to the rehabilitation. And because of suicidal ideation and real severe self-harm pressure, she was admitted to our psychiatric ward again in March and received another ketamine infusion. And afterwards, she was able to do an intensive psychotherapy as an inpatient for several months. So, round about 3 times before this conference, I met her for a follow-up, and I measured the back depression inventory and the BSL-23. And these changes occurred. And here you can see clear improvements. So the back depression inventory from baseline changed from 34 to now 15. And as I said before, 34 means a severe depression, and 15 is considered as a mild depression. And also, so these are changes of 56%. So during the month from December to August. And also the BSL-23 changed from initially 63 to now 34, which means a decrease of 46%. So this is a clear improvement. And now when we compare what happened, what changed before and after the ketamine infusion, we see that this year she spent just also a long time at our psychiatric department, But for the first time since she received the ketamine infusions, she was able to complete a full and intensive psychotherapeutic treatment as an inpatient, whereas in the years before the ketamine infusions, treatment were characterized by many crisis intervention or therapeutic discontinuities. So, and the most astonishing thing is that after the ketamine infusions, till August this year, she injured herself only twice. And this was in March. And once she cutted herself with 11 really deep cuts, and once she swallowed a piece of glass. But when you compare it to the following years before she received ketamine, over 1,000 really severe self-injuries occurred with an almost daily frequency. So this was really a clear improvement. And she had several emotional crises, but no suicide attempts occurred after the ketamine infusions. So she said that she was doing very well at the moment and felt little pressure to harm herself. And in psychotherapy, she was able to learn new strategies to deal with emotional regulation. And she is able to see the consequences of her action and is distanced from acute suicidality. And self-injury is currently not an option for her because it would cost too much effort, time, and pain, she said. So she lives in a shared flat again and begins to study chemistry just in a few weeks. And she's now she's seen on a regular basis in our outpatient clinic, and her current medication is quetiapine 200 milligrams per day. So while these results are really promising, there are also some limitations. And this is just one case report and an uncontrolled observation. And the improvements might not be related to ketamine. And we cannot exclude the possibility that the benefits are due to the time-consuming procedures of the ketamine infusions or the increased attention which is associated with the treatment or a placebo effect. So while these results are so promising, we still have to be really cautious, and further studies are needed. And for our future research, we are planning a study to evaluate the effects of ketamine on suicidality in borderline personality disorder. So our hope was that ketamine would open a door for her to profit from the well-established and guideline-based psychotherapeutic methods by reducing suicidal ideation and severe self-destructive behavior. And in this special case, our expectations were met. So thanks a lot for your attention.
Okay, thank you so much. See, people can't even wait to lift their hands. This was a very, very impressive talk. Thank you. It's moving to hear how this patient that suffered so much was able to relieve her symptoms. Okay, so the question's yours, the first one.
Wonderful presentation, thank you. I wondered if you could say what the dose of the infusion was, and also if it is typical to give 2 infusions and then wait for the patient to come back for the next. Thank you.
So the dosage of the infusion was 0.5 milligram per kilogram body weight, and her body weight was about 60 kilograms. So we calculated it, and we do it with our anesthesiologists. And it's not common to give it on demand. we did it with this patient. So we have a structure. So we give one infusion. We treat a lot of patients with ketamine, not with a borderline personality disorder, but with a treatment-resistant depression. And the first infusion, we look, is it feasible? Is the patient profiting from it? Or is it worse for him? Would the patient continue or not? And then we give infusion twice a week for about 3 or 4 weeks, and then we discontinue the infusion duration, and sometimes we give infusion every 3 months or so. But this was a bit unconventional for us. Yeah.
Do we have a question from our audience? No. First, sorry if somebody else was quicker, but please.
Hi, was there any preparation or integration sessions in between the ketamine sessions?
Not on a regular basis, but when she was at our ward, we tried to integrate the experience she made while the infusions in psychotherapeutic sessions. Yes, we did it. And in March, it was impressive. She told that she experienced while in infusion the fear of death, and she reported afterwards that through this experience she realized that she didn't want to die, and this we named up in our sessions and talked about it. Yeah.
Good. We have time for one more question. I see your light is on. Did you want to ask something now? Yeah?
Thank you for a terrific presentation. That was great. You partially answered the question I wanted to ask just now, but I'm going to ask it anyway. The benefit that you reported in this patient, assuming it was due to ketamine, to what extent was it mediated by insight or mystical type experience, and to what extent was it just getting the molecule to the brain? If you could comment on that, that'd be great.
Yeah, I asked the patient what's her opinion for the benefits, and she said she don't know, and she doesn't believe it was because of ketamine, but because of pressure that she can't study, or because she received psychotherapy. So she didn't link the benefits to ketamine, but it's a great, it's a huge possibility that this is linked to ketamine because these improvements weren't, she wasn't able to have these improvements before the infusion. And she didn't report about any mystical experiences. For her, it was really uncomfortable. So she didn't have any good impressions or comfortable impressions of the infusions. Yeah. I hope that answered your question.
Okay, perfect. Then, once again, thank you so much, Helena.
Yeah, thank you. And I'd like to... I'd like to finally thank my research group of Stefan Borgward, Mihai Avram, and Felix, who made this possible for me. So thank you very much.